Well, welcome. I'm Shirley Fenton, the Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today as we continue our series on health informatics tools for the future. We also welcome those of you who are joining via our webcast of this seminar. Just to note that this webcast will be available soon in our archive of seminars, and of course you can view those 24/7 from the Intranet website. A special welcome to our speaker, Sarah Friesen. She is the Vice President, Supply Chain for Hospital Business Services. And before we begin, I have a couple of announcements. I'd like to tell you that our next seminar will be April 20th. Jim Anderson will be our speaker, and he'll be talking about the human side of health informatics. Before we begin, I want to give a special thank you to our seminar sponsor, Ormed Information Systems Limited. Chris Sherbach, President and CEO, and Steve Coggers, Vice President Sales, are here today. Chris and Steve, could you acknowledge where you are in the audience? So with that, I don't want to take too much time from our speaker. I'll introduce Dominic Covey, the Founding Director of the Waterloo Institute for Health Informatics Research. He'll introduce our speaker.
I don't know how I'm supposed to hold all this stuff. This is a real challenge here. But as just a general point is that I think as a group and in all of our seminars, this is finishing the third year, I believe, of seminars. And we've never had speakers in the area of what I call administrative informatics. And this is anything from supply chain management, which Sarah will talk to us about today, to areas like performance management and the operation of the health system, the modeling of the health system, and so on. And next year, in our new seminar series, we intend to correct that. We won't focus entirely on that, but we're going to add a number of talks in this area. The number of groups here at Waterloo would be interested in this, management sciences being a key one, accountancy, School of Accountancy being another, and some people who are in computer science in the area of e-commerce. So we're trying to appeal to another side of the house as well as to the clinical people, and probably what we'll end up doing is alternating, so we keep both groups of people interested in the entire program. So this is our attempt to, this year at least, have one major presentation in this area. The other thing I wanted to mention, I believe we got the confirmation from Mike about the talk. Yeah, Mike Connolly will also be talking here in 2 months from now, I believe it is it? May 25th. And he's the leader of the Smart Systems for Health Agency, and he's got some incredible ideas and seen health informatics from a very high level. So at the end of this series this year, we got the 3 more talks, we're trying to hit on some very important topics, and I'm hoping it will be meaningful to everyone. I also want to make a point. We did a quick survey and found out that we have over 1,000 hits per month on this material we produce in health informatics. And what that means, and we know a number of students are promoting this across Canada, is that these talks get widely seen, and we're pleased about that. And hopefully, even if people who listen to these have ideas about talks that we should have, we'd like to know about those. So a couple words about Sarah. I've not had the privilege of meeting Sarah, but I heard about her from a talk I believe you gave at McMaster, was it? Or in one of the major meetings, I can't remember. And I had associated you with McMaster at the beginning, as you know, by mistake. But we actually got the word on Sarah from other people in the field, so she's an excellent speaker in this area and brings a lot of content. Right now, as Shirley mentioned, she's the Vice President of Supply Chain for Hospital Business Services in Toronto. And 16 hospitals in the Greater Toronto area are involved in this. And this is a major effort. In talking with Sarah, she mentioned that they put this together from nothing. And it's a very, very difficult area. You may not know, but the minister was yelling and screaming about this about a year ago, that the hospitals needed to do something like get together in their purchasing services. And unfortunately, the hospitals widely have not responded to that. But this looks like the beginning of a very, very important response. She's on secondment to HBS from Shared Healthcare Supply Services, where she's a general manager. Sarah's the co-chair of Hospital Supply Chain Network, a member of the OntarioBuys working group, and she'll probably talk to you about that. She's also developed and leads the Healthcare Supply Chain Management course for Executive Center for Supply Chain Management and Logistics management at York University's Schulich School of Business. So Sarah, you come to us with great recommendations and a nice background, so we can't wait to hear from you.
Thank you, Dominic. Thank you very much. Just step over the cords. Well, thank you. It's my pleasure to be here today. It's always interesting for me to share what we're doing with supply chain management in healthcare. This has been a very exciting few years as we have seen the interest in supply chain in healthcare increase from a very low level of, they belong in the basement, they just process orders, to understanding the strategic benefit that a really robust supply chain can provide to a hospital or any other healthcare organization. As Dominic indicated in his introduction, I wear a number of different hats, and so I have decided today to bring this presentation to you courtesy of the Healthcare Supply Chain Network, because it's the one that has the sort of global interest in what's happening. So I'm briefly going to give you an environmental scan, what is the nature of the healthcare supply chain today, then talk briefly about what a simple supply chain management framework might look like, talk about some of the current initiatives that are going on, and that, of course, will include a brief update on hospital business services. So from the point of view of the environmental scan, in 2001, the OHA, which is the Ontario Hospital Association, and a group called Efficient Healthcare Consumer Response did a task force report on supply chain management. Even though that's a few years old, the findings from that report continue to really be relevant in trying to describe what the healthcare supply chain looks like. So I tend to still quote from this because I find it really, really useful. And the report was really focused on trying to demonstrate how best practices could reduce cost in the supply chain and also could reduce medical error. So just to provide you with some of the background, when we did this task force report, we went out and tried to get sort of a state of the nation on what was going on with hospitals, because that, of course, was the OHA's primary interest, and what was going on with suppliers. And it found that hospitals were really challenged in trying to deliver supply chain savings because they tend to provide service at the local level. And again, as Dominic said, there hasn't been a lot of aggregation of hospital spending, at least in Ontario. We've seen a lot more of it in other provinces where the governments have legislated regionalization. So this was focusing on what was going on in Ontario. Physicians don't report to the CEOs. So physicians aren't actually hospital employees, and this is a really significant issue because it means they have no real accountability to the bottom line. So trying to bring them on side when you're looking for cost savings measures can sometimes be a bit of a challenge. Healthcare doesn't lend itself to traditional optimization strategies. A large part of that is caused by the fact that typically it's difficult to invest in administrative support functions within hospitals because of the way funding is controlled and because of the funding envelope that hospitals receive. That money is typically and appropriately directed into direct patient care related services and capital. And so it's hard to create, for example, a more efficient supply chain when you can't invest in the technology that might help you get there. And finally, there are really inconsistent levels of technology, processes, efficiency, resources. There are excellent competencies in the system, and there are still some competencies that are not where they sort of not up to private sector standards, and so that has caused a lot of the issues in the hospitals themselves. What the report found on the supplier side was that the top 50 medical supply and pharmaceutical suppliers deliver about 60% of the purchases. We've done some more validation of that in the past couple of years, and indeed the number is actually shrinking or growing, depending on how you look at it. There are fewer suppliers who supply more of the items because of the fact that we have had a lot of mergers and consolidation in the supplier community. Interestingly, we were talking before I came to make this presentation about some of the opportunities that the private sector has taken advantage of in supply chain. And they have generated billions of dollars in savings from taking advantage of these opportunities. So they inform us in terms of how do we get at leading practices for healthcare so that we can start to benefit from some of these cost savings. I've put up a couple of classic examples, such as the just-in-time delivery system used in the automotive industry. And we all know just how much that has saved that industry over the years, well, at least in sort of in a large sense, we know. And interestingly, suppliers saw at the time of this report, and I think to some degree still do see, that hospitals want to focus on the lowest price. They're not always looking for the best value, and which can actually translate into overall supply chain efficiency. So one of the huge opportunities is to try to get hospitals to a critical mass. And in the report, it sort of stated that 75% might be a relevant mass to be achieved in order for suppliers to actually gain further benefit from the system. So that means 75% of hospitals using best practices. In summary, the report found that Ontario hospitals really aren't taking advantage of supply chain opportunities. And again, that an efficient supply chain could significantly reduce costs through the implementation of best practices and strategic sourcing. The figure that the report conservatively targeted was about $350 million across Canada. The report also focused on how the use of best practice and technology could reduce medical error. And that is certainly an area of focus for many in healthcare outside of supply chain, looking at how to improve the use of point-of-use technology, et cetera. And the report had quoted a study from the U.S., actually two different ones, that saw an 80% reduction in medical error as a result of using the appropriate practices and technology. The report also said that most of the savings that were left in the healthcare supply chain would likely be found in hospitals, not within the suppliers, and that's consistent with the notion that hospitals needed to get more efficient in order for suppliers to see any incremental benefit. And finally, that the implementation of supply chain best practices would improve patient outcomes. So let's just talk about that a little bit, because that's pretty germane to anything that we do when we work in healthcare. A number of years ago, Deloitte & Touche did some work with Sunnybrook and Women's Hospital in Toronto. And I was part of this process. So we did a survey to try to figure out how much patient care staff time was being spent on non-core functions. So in other words, you know, how much time was a nurse spending chasing supplies because they couldn't find them on their carts, or calling suppliers because the purchasing department wasn't being responsive. And we came up with a number of 15%, which translated into a very significant amount from a dollar perspective. So I'm pleased to say that that number has been significantly reduced at Sunnybrook since 1999. Certainly, when you have a robust supply chain and you have everything where it should be, you eliminate the need for patient care staff to perform the non-core activities. And the impact on patient care delivery, again quoting back to the study, is that there's a dollar benefit in terms of the impact of reducing risk and errors, and also just an overall patient outcome benefit, because you're reducing OR waits and cancellations when you have the products that you need to deliver the patient care. So what are some of the critical success factors in achieving supply chain optimization? Well, clearly securing the buy-in of senior management is key. It's one of the big challenges that we have found as we, in this case I'm speaking in terms of hospitals, but also the healthcare supply chain network, is trying to engage senior management attention so that they understand the benefits that can accrue to their hospitals by investing in the supply chain and understanding this potential strategic impact. Setting common goals and standards among hospitals is also very important. If we're ever going to reach that 75% critical mass, we all have to be doing things differently. And so in a little bit, I'm going to talk about the healthcare supply chain network and how we're trying to facilitate raising the bar so that we have more common standards. Obviously, training and developing supply chain professionals is a big part of this. That's why when I was given the opportunity to set up the healthcare supply chain management course at Schulich, I was delighted to take the opportunity because it is a way that we can reach a number of healthcare, meaning hospital and supplier individuals over the course of a year. So it's proven to be very successful. And we need to raise the bar because if we want to truly be strategic in the way we do our sourcing in particular, we have to make sure that we have the right competencies in place. And finally, securing government support. Government support in terms both of backing the notion of universal standards and also in funding initiatives. And Dominic, in his introduction, mentioned OntarioBuys, which I will also speak about because that has been a truly exciting opportunity for us to get some of the funding directed to supply chain. I mentioned earlier that clinicians, physicians in particular, don't report to CEOs. Having their cooperation is really key to success in achieving a lot of standardization opportunities within a hospital. And so it's really important to get them on board, to engage them in the process, to find ways to work collaboratively with them so that they see themselves as part of the process and want to help foster the success of the initiatives that are underway. A good way of selling it to them is by demonstrating that you can free up their time to spend on patient care and also hopefully free up dollars that can be redirected into patient care as opposed to being spent on inefficient processes. Also, in terms of supporting research and program development, when we go out to tender with our contracts, we usually include a component for research, development, education, and that keeps them also very interested. And then, as I've been indicating, clearly these are all ways to generate operating funds through the savings that you secure. So just a brief overview of a supply chain framework. This is a very simplistic one from inside a hospital, but it will just give you a flavor for those of you who may not be that familiar with what makes up a supply chain. We've broken it into 4 main buckets here. The first one, which we call plan, is the one where you are deciding what it is you need to buy. And typically in a hospital, that is heavily clinician-driven because they're the experts, they're the ones that know. It's just like at Bell Canada, it's the engineers. You know, or in an IT company, it's the IT people. It's the people who know and understand the technology who have to recommend what it is that you go out to look for on their behalf. So that then becomes the sourcing component where this hopefully strategic sourcing department is identifying the suppliers, is doing managing the RFPs, and is actually securing the products and bringing it back into the hospital. And in many supply chains, the accounts payable function is part of that. The manage function is the function that takes care of receiving the goods. If you have on-site inventory, putting them away and picking them again to deliver to the patient care units, and also then disposing of any goods that may have to go back to suppliers. Again, in some hospitals, it will also include sterile processing as part of that function. And finally, deliver, which is the very end point of getting the products out to the patient care units. Underpinning all of those are a number of different processes. So those, the blue line are your basic operating processes for supply chain. In the green section, what you're talking about are the management processes that support that. And as with any good management system, you have to have policies and procedures and a good performance measurement program to support all of the above. So because this is has been my area of focus, I decided to include a slide specifically on strategic sourcing, just to give you an appreciation for where we've come from and where we're moving to. So a few years ago, we would have been down in the bottom left-hand corner where the purchasing people truly were order takers, and all transactions were happening by phone and by fax. We've moved to an era where we have a lot of contract specialists now in many of the hospitals. We are becoming more electronic. Many more transactions are done through EDI. We're moving to online requisitioning and developing closer alliances with our suppliers so that it's a more collaborative type of relationship. Where we're headed is to be true strategic managers, where we are e-sourcing everything we possibly can. We're truly integrated with our suppliers, and which is germane to what we'll talk about later insofar as an initiative like hospital business services, reorganizing the organization so that accounts payable becomes part of the supply chain process, and you look more and more at shared services. And of course, the benefits of doing that are quite tangible because by being more strategic, you're able to improve efficiencies, streamline operations, and this does lead to the generation of a significant portion of the cost savings that are available through supply chain optimization. And you do that by leveraging your total spend, by using vendor-managed and consignment inventory strategically, by standardizing and simplifying your processes, and also, of course, by leveraging technology. So the organization that I worked for before I was seconded, and that I still work for, is Shared Healthcare Supply Services, and it's an example, a small example of a shared service organization. So it represents 3 hospitals in Toronto that have come together to do their purchasing in order to achieve these strategic goals. But importantly, you also have to look at creating an end-to-end supply chain. So we work very closely at Shared Healthcare with our sister company, which is called Hospital Logistics, and they provide the warehousing and distribution support to the same 3 hospitals. It's really important that you have that end-to-end supply chain so that you're, again, so that your patient care staff don't have to worry about any piece of it and can focus on their business. So let's move on and talk a little bit about some of the current initiatives that are underway. As I indicated, I'm making this presentation on behalf of the Healthcare Supply Chain Network. It's pretty much a grassroots organization that was founded in 2002. We put it together out of the OHA EHCR task force report. There was a group of people who saw the need to create an organization that could actually deliver against the recommendations that came out in that report. The Healthcare Supply Chain Network represents a very broad spectrum of the healthcare stakeholders. This no longer is focused just on hospitals. On the next slide, I'll give you a flavor for some of the organizations that are represented on the board of HSCN, but they include hospitals, they include technology providers and suppliers and consultants. Really a good spectrum of the whole supply chain, including pharmaceuticals. Our vision is to promote safe and quality health care through the implementation of optimal supply chain management practices. And we have set 2 primary goals for ourselves in the short term. one of which is to establish and promote leading practices in supply chain, and those leading practices are taken from wherever. They aren't necessarily born out of healthcare, and also to develop and deliver educational support to members. So we are working very hard on both of those goals right now. We are getting now to the point where we actually have many leading practices that are under development, which we will be posting on our website. So this, again, as I said, just gives you a flavor for some of the suppliers and hospitals that sit on our board. And as you can see, although it might not be immediately obvious, from a hospital perspective, we are very much a national board. We have members all the way from Halifax to British Columbia. So that's really exciting, including a member from Quebec. So we consider ourselves to be very much national in scope. What are some of the things that we've done? In September, we were the advisor to Canadian Healthcare Manager magazine in setting up a healthcare supply chain summit, which was modeled on the eHealth Summit, which I know many of you are familiar with. And the purpose of that was actually to try and reach out to senior management in hospitals in particular to get them in the room to understand more about the strategic benefits of investing in the supply chain. And it was a very successful event for the first time of doing that sort of thing. So we're looking forward to doing that again. I've already talked about our involvement in generating leading practices. And there are a couple of different issues relating to that I'd like to highlight. One is that we have been collaborating with OntarioBuys, and while I'll explain what that is in more detail in a couple of minutes, OntarioBuys is an initiative that was announced in the Ontario budget last year that specifically funds initiatives in the broader public sector supply chain. So healthcare has certainly been taking advantage of that, and I have some examples of some specific initiatives that we have been developing in order to use that investment. And then, of course, I've talked about the practices that we're developing. We also were involved in a discussion paper on the state of e-commerce in the Canadian healthcare industry. This was an initiative that was funded by Industry Canada, and then with the assistance of Deloitte, we did a survey across the country to try to get a snapshot of where hospitals, this was very hospital specific, stood with respect to e-commerce technology. And it was an interesting first attempt at that. We got some good information out of it, but we think we need to go on and do a more in-depth study in order to really have a good appreciation of where the hospitals are at. And finally, we are very focused on education, and as Dominic mentioned, one of the avenues for that is the program that we deliver at Schulich in Toronto. So a little bit on OntarioBuys. It's a sector-driven initiative. Its intent was to supply multi-year funding for the broader public sector. So that is, in addition to healthcare, it's universities and also school boards. So a working group has been created to work through how we can actually get the funding out into those sectors to start to improve supply chain. Their vision is one of integrated supply chain management. When they first started, I think their vision was really focused on integrating the supply chain across the three sectors and getting one large supply chain initiative in place. But I think we've all come to realize now that we need to be more sector specific in how we start this, although longer term there still, of course, are opportunities to bring it together into more of a holistic effort. Like Healthcare Supply Chain Network, their primary mission is to get best practice information out into the hands of the supply chain practitioners so that they can they can actually begin to implement these best practices. And their values are definitely based in the notion of public service, integrity, and of course efficiency and effectiveness, because that's what the whole initiative is supporting. We have actually just come to the end of the first year of OntarioBuys. The working group had a meeting just a couple of weeks ago to talk about what had we accomplished. So this is a slide that I put together closer to the beginning of the year, and I left it in because it's interesting to go through now and see just exactly what we've been able to accomplish. Starting with the second point, there was definitely a working group that was formed that operated as a sort of a steering committee to generate ideas and to push the notion out into our respective sectors. One of the tasks of that working group was to create an inventory of existing practices within the broader public sector, and we did do that. OntarioBuys also wanted to prepare 2 documents. One, a compendium of supply chain best practices, and the second then a handbook that was sort of a how-to manual. They have absolutely put together the compendium. We worked on that over the course of the year. And actually now OntarioBuys and the Healthcare Supply Chain Network are working in collaboration on how to disseminate the information, what's the best way to get it out. This is just from a healthcare perspective, into the hands of the practitioners. And of course, looking for similar opportunities in the other 2 sectors. OntarioBuys definitely put money aside to financially support specific projects, and I have some examples that I will share with you. And then also it wanted to provide advice to the government on the creation of a permanent entity within the government, and they are now working on staffing a supply chain secretariat within the Ministry of Finance that will be overseeing these types of initiatives in the future. So it has been, all in all, OntarioBuys has been extremely successful this year. I'm only going to speak to the healthcare projects that it's funded. We've taken a bit of the lion's share this year because we've been kind of eager and interested and ready to go. So one of the initiatives that is receiving support from OntarioBuys is definitely hospital business services. There is also a significant e-supply chain project that is happening with 6 hospitals in Ontario, representative hospitals from different regions of Ontario, looking at how to facilitate and expedite the implementation of e-commerce in those hospitals. So shared healthcare is one of the participants in that, and of course we represent 3 hospitals through shared healthcare, so there's really more than 6, but it's 6 entities that are participating. And some of the examples of the types of things that we're working on are a more rapid implementation of online requisitioning, the implementation of e-catalogs. I've listed barcoding and EDI. There's a separate project looking at how to quick start more hospitals who aren't using EDI at all by providing some funding to them to get that started. We're looking at contract management databases. There's just a whole host of initiatives that are part of this. And the 6 hospitals were 6 entities that are participating were chosen because we tried to get representation from as many different enterprise systems as we could, so that as we develop technology, if it worked in one hospital that was using, I'll just use the system that we use at the 3 hospitals I represent, GX SmartStream, then another hospital that was using SmartStream could easily adopt them. And finally, there is a project they're working on how to reprocess single-use medical devices. That's a process that is only right now available in the United States, and so we're trying to find a way to bring that to Canada safely. And so finally, I'm going to speak a little bit about hospital business services, which is my new life since a couple of weeks ago when I took on the secondment. This project has been going on for over 2 years now. And as Dominic mentioned, it is the coming together of 16 hospitals from within the GTA. They were part of 2 different groups of hospitals. The acronyms are there. And really the core of this is that it was an opportunity for these hospitals to work together to create a shared service organization that would support the business support processes of these hospitals. And so the project has been focused on the supply chain, which includes purchasing, logistics, and accounts payable, as well as elements of human resources, payroll, and then elements of the general ledger, accounting, and financial reporting functions. So with an intent in the bottom to leave the really strategic core functions still within the hospitals. This is really about removing, except for with respect to supply chain, about removing the transactional processes. This is just a little bit of a timeline that was developed to show how the 2 different groups, the 10 and task groups, moved this forward. Really, the more exciting activity has happened laterally in 2004 and then now in 2005, as we have gotten the go-ahead from the 16 hospitals to work on developing this organization, and it has been incorporated, and now we're all, the senior management team for Hospital Business Services has been seconded largely from other hospitals to provide the leadership as we work through the issues of starting up this organization. There were a number of benefits that were identified as to why Hospital Business Services, which is what we are calling ourselves these days, would be a good idea. First of all, of course, the opportunity to achieve economies of scale. Similar to the objectives that I addressed earlier in my presentation, there are huge opportunities when you bring that many hospital purchasing groups together to leverage your group purchasing, as well as to look for opportunities to standardize, both in terms of products and processes. Obviously, an opportunity to reduce operating costs of administrative services by bringing them together in one organization as opposed to having them spread throughout the different hospitals. And with the notion, again, being to invest the money that was freed up in direct patient care. And also driving continuous process improvements, ensuring that we continue to optimize the supply chain, to find different ways to standardize, and to develop a good set of performance indicators so that we can measure what we're doing. Further benefits included improving the information technology component, developing and implementing an integrated system so that we could have better decision making and deliver better information to the desktops of hospital managers, as well as within Hospital Business Services itself. And integrating common systems also facilitates pooling savings and helps to make affordable the investments required in IT infrastructure. And also not to beat a good horse to death in terms of, I know I've talked about leading practices a lot, but this is also a way to put those into practice and on a larger scale so that we can really start to see some of the benefits. From the systems integration perspective, the business case looked at these, the opportunity across the 3 streams, as we've called them, to leverage the benefits of the integration and the synergies. So clearly there is scale possible with transactions from all the streams that will reduce the cost per transaction. Planning and implementing new information technology will be greatly facilitated by taking a three-stream perspective to create a common IT infrastructure, and integration across the streams will also be possible through payroll and accounts payable. So bringing that all together under the one roof and into the one system. This is a very high-level snapshot of the business case that made it very compelling to move forward. Over the course of the 2 years that have led up to where we are now, we spent a great deal of time working through the opportunities, developing organizational models, and looking at what the potential was if we went ahead with this project. These are as I said, the high-level financials. As you can see, from the point of view of the savings that ascribe to the functional areas, we're looking at a range of about $10 to $13 million, which is very significant. Further improvement on spend savings in the sort of $8 to $12 million range. IT savings that relate to the improvements in systems and integration within hospital business services in the range of $1 to $3 million. And then on the bottom, there was a sort of an attempt to get at what the investment in this might be. So we saw a high investment near $50 million, but a more reasonable one near 40. So what this really translates into is about a 3-year payback for the hospitals who are investing in this. And finally, one last supply chain slide just to give you a notion of what we've worked on with respect to the supply chain for hospital business services. So clearly we're looking at taking this from the hospital to the purchaser into the shared service, which will do the strategic procurement, provide the customer support and customer service, and all the information management and analysis, and then push that out to suppliers and distributors who will then send the products back in to the hospitals, and of course with a link to the banks now, because accounts payable will be under this umbrella, and we will be able to close the loop on the supply chain. So that's the end of my formal presentation, but I certainly am pleased to take questions.
Thank you, Sarah. I want to kick that off on a couple of points, if I could. One is, how much value is in the supply chain? How much actual money is in the supply chain in a given year? Do you have any idea?
Not on a national basis. I couldn't tell you that.
No, on like a provincial basis or anything?
Well, why don't we take shared health care as an example? In a given year, we would purchase in the neighborhood of $300 million worth of product.
And that's across
3 hospitals.
3 hospitals. Wow. And we've got about, what, 50 hospitals in the province?
More like 150.
150,
yeah,
okay.
Yeah.
So that's
but
interesting.
Varying sizes, of
I think
course.
when you said the total savings across the country were only $350 million, I mean, I see that level of savings being in a single province if those numbers are true. So you said it was a conservative estimate. It obviously is. And do you have any comments on that about how that was derived, or?
Yeah, not specifically on how it was derived, but it certainly, given that that number was made up of both savings from consolidating spend as well as from implementing more efficient practices. You are quite right. It was a very low estimate. I also think that now we know more about what we're looking for, and so our estimates are probably more realistic now than they would have been at the time of that study.
Okay, I think it'd be interesting to know that figure, because the government's certainly making a case that the number is very large and that the potential within Ontario alone is very substantial. So normally Ontario is about 40% of the spending in the country. So it's a pretty big number, and I expect way beyond that. Questions and comments from people? And I'll hand you, or Shirley will hand you, a microphone, so if you have any questions or comments.
Thank you. Can you hear me? I'm just wondering about the impact of the vendor community and how they provide products and services to the hospitals, and also the implications around distribution networks. Like a good example would be Source Medical for here in Ontario. So what happens with that type of evolvement of distribution networks into healthcare as opposed to sort of the typical supplier in the whole supply chain perspective?
Well, there's no question that consolidating distribution is one of the objectives that we have, because we want fewer trucks showing up at hospital docks. They tend to be pretty old, pretty small, and out-of-the-way places, and there's a lot of double and triple handling that goes on in many hospitals. So the more efficient we can become through consolidating the distribution, the better off we are. So many hospitals have taken advantage of that by capitalizing on the distributors that are out there and available. Sorry, in terms of the impact on the suppliers, do you mean in the sense of how do we engage them in this process, or what is the impact on them if we, as we start to consolidate?
It seems like to me that consolidation is going to continue to grow if supply chain execution is driving more consolidation. It seems kind of that the likelihood of small suppliers being sort of supplying traditional
Well, so I'll just repeat the question for the benefit of those who might not have heard. What the gentleman is asking is, what's the impact on smaller suppliers as hospitals continue to consolidate, and presumably there's more of a shifting of product to through standardization to a smaller number of suppliers. I guess what I would say is that while we certainly see that consolidation taking place, and as I pointed out, taking place within the supply community itself, as more and more companies are merging, but from the point of view of the healthcare system, there are an awful lot of suppliers who are specialty suppliers. And so even though we may consolidate large purchases into the hands of a smaller number of suppliers, I see that specialty suppliers as continuing to maintain their niches because they make products that aren't available from some of the large suppliers. So I think there will be a mix. As with any good purchasing effort, there's always an ethical component which tries not to put suppliers out of business. And so that is something that we are very much aware of and trying not to have that be an outcome of this.
Other questions? How about you guys?
I wonder if there's been any attempt to determine what level of cost savings would accrue to the province overall just from regionalization. I mean, certainly looking at other provinces across the country, Ontario's certainly taken more time, perhaps more of a humane approach in regionalization. And I wonder, A, if there's been any attempt to determine what level of cost savings are available through regionalization alone as a component of the overall cost savings, but also looking at some of the other regional models in other provinces to see if, in fact, they have accomplished any cost savings. There's been a little bit, I think, a lack of information on a before and after case to determine whether or not regionalization actually is the answer.
I can't comment so much on the benefits within the other provinces and whether or not they've achieved the objectives that they set out to. I do know that within Ontario, when we, through OntarioBuys, there was an effort to look at the province as a whole, and not so much to look at it from the point of view of what if it was regionalized by the government, but what if there were many hospital business services that grew up all over the province that were able to take on this initiative and reduce costs. So the government may have done an analysis of regionalization in Ontario. I haven't seen that, but I do know that through the work that's been done through OntarioBuys, that indeed they have identified that bringing organizations together, creating these shared services type of models really will result in some significant cost savings. So, sorry, I know you'd probably like a number, but I can't give you one.
Other questions or comments from anyone in the back? I don't want to miss anyone. One other, several questions. One, has anyone actually modeled the supply chain in the sense of simulation, for example, and studied this or tried to create like where are the savings, where are the bottlenecks and that kind of thing? Has the supply chain been put together in some sort of a mathematical model?
Certainly through the work we did on the Task 10 working group that was looking at supply chain, we didn't necessarily run a sophisticated computer model, but we looked at all different aspects of the supply chain. We put in all the current costs, and then we did do some modeling around what would be the impact, if we achieve certain levels of efficiencies. And so I think the answer is yes. It's just, to what extent we followed some of or used the models that have been used in the private sector. I'm not sure we did quite follow that path.
It might be interesting to have that kind of information and to be able to experiment with it. I know there are a number of people here at Waterloo who are, and well, Toronto as well, but who are very much into that area. And being able to see the opportunities, and actually measure what the possibilities are might be useful, particularly with the magnitudes of numbers and the dramatic need for investment right now. Making that decision might be facilitated by that. I understand, and I've had a lot of really excellent, as Shirley has, with conversations with Chris Sherbeck, who's been sponsored this session, and it's clear to me that there's still a very large amount of data development that needs to be done, and that if we knew better what happened in the chain, where the bottlenecks were, where the problems were, where the opportunities were, there might be a more rapid adoption of the technology. I don't know if I could say that, if you could say that better, Chris, is that okay? And I'm just curious, are other people doing that now, or is that?
Looking at modeling and yes,
and studying. And
absolutely. I think that and again, I'm going to come back to OntarioBuys because I think it's really been a catalyst in driving different regions to look at the opportunities for cost savings and what would it mean to aggregate, smaller or larger groups of hospitals to try to get at what the savings would be. So, I definitely think that that some of that work is going on through OntarioBuys.
I want to make sure I don't miss anyone's questions. You used the B word during your talk. That's the best practices.
I know.
How did you come to those? There's a compendium of best practices.
Well, actually, that's been an interesting discussion point. Within Healthcare Supply Chain Network, we only call them leading practices because we don't really believe that there is any one best practice. But the OntarioBuys slide was quoting from their mission, vision, and values, and they used the B word. So we've had some interesting discussions with them, and I think we have brought them around to our way of thinking, and their compendium that they just published is a leading practice compendium.
So they used a weasel word around this. Is that the idea? The W word instead of O.
That's absolutely.
That's sort of the Canadianization of the U.S. version, right? Sorry, I didn't mean to do that. With regard to that, clearly those practices again, are the result of real studies, or should be.
Yep.
One can imagine a lot of opinion getting into this, and again, there's an opportunity for development of real evidence. And I don't know, it'll be interesting to know what's been done. Maybe in a future presentation, we can get answers to some of those questions and get perhaps some of the deeper level simulations and so on of this might be interesting. There's a group at McMaster that led us to you. I don't know how that happened exactly, but they seem to have quite something going there. They had some sort of a major symposium on supply chain management. Are you aware of that? I mean, or is,
Not at McMaster, no. And I know you and I talked about this before, and I wasn't familiar with that.
There's actually a website on this and things, and if anybody's interested, we can provide that and what that is. But I'm curious about to what extent there's research and data development being done on this, and it might be interesting. I guess the other question is, we talked beforehand, and I mentioned I've had a lot of association with diagnostic imaging departments, and the favorite time was 2 or 3 years. There was the renegotiation of the film contract. Well, now it would probably be the renegotiation of the PACS contract. But part of that was the getting of benefits for signing with Fuji instead of AGFA or the other way around. Included things like teaching file that was worth $100,000, or who knows, a trip to some country in South America. Whatever it was, there were benefits. And I thought you had an interesting response to that you've not lost that ability to derive some of those subsidiary benefits despite the centralization. Could you talk about that a bit and how you do that?
Sure. Whenever we put together an RFP and plan to go out to market, we put together a committee of the relevant stakeholders. And so if the RFP happens to be in diagnostic imaging, then all the stakeholders would probably come from that department and would have input in terms of what their clinical requirements were. And that would include them indicating where they might need educational benefits or program support and that type of thing. So when we go out to RFP, we will ask for some added value benefits, such as supporting education for nurses or physicians. But when we do ask for those kinds of benefits, they have to be very, very tangible and very hospital specific and directed to the clinicians as a group. So it's I think it's our effort to try to bring everyone on side and find a compromise that is good for the hospital, because we still can negotiate a better price, but still provide some of the educational support that the physicians and nurses find of value.
Now, I mean, to me, that sounds like obviously bringing the team together is one thing. That's hard, but it seems like you've got a very complex process here yourself. So you've got the broad supply chain management thing, but you must have a fair amount of technology to manage the problem of the RFPs and the responses and everything, I assume. Is that true? Or
yes, absolutely. I mean, we tend to do a lot of, increasingly we're doing more and more of our RFPs electronically in terms of sending them out to market that way. And then we do have to do our own modeling when we bring them back in again to ensure that we are achieving the best overall value for the hospital.
I've heard there are still quite a few, and I don't know what your organization's like, hospitals that when they go through this process every year, it's effectively a paper-bound process. I've heard described a wall of whiteboards covered with suppliers and things like that. You're not in the same position, you're saying. You're able to a degree at least, support that through technology.
Yeah, it's really been an effort of ours to get there.
Okay, interesting. A final thing is I can think of, and I invite anyone with questions to put your hands up, is there any loss of quality here? Is there any loss of, I guess, the hand of the health system in this? Are there any dangers in this, if you want? Not that they're necessarily there, but what are the things you've got to avoid to make this so that the quality of this supply acquisition process and so on is at least as good, if not better, than it has been in the past? Not just that it's cheaper, but it's as good or better, so you don't have wired procurements and things like that.
Well, as I was saying in terms of how we get clinicians on board, if we couldn't demonstrate to them that they were going to get the same service or quality or better than what they were able to get if they went out on their own, then we wouldn't get very far. So certainly we take the position at Shared Healthcare of purchasing best value, and best value has to include quality, price, and service. So I think that, you know, as I said, in the OHA report, they found that there still were a number of hospitals in the system who were looking for lowest price. And in fact, that practice was not resulting in more purchases flowing through the purchasing department for a lot of the reasons that you suggested, because they weren't necessarily getting the best product for the given need. So you have to find the balance, but the important thing is demonstrating the value add by showing that you are the business subject matter expert, that you can negotiate the better deal and give the end user and all the value that they think they're looking for, as well as benefiting the hospital.
And there is an agreement that the procurements go through you. In other words, somebody can't go around you if they're a member of that group?
That's right. I mean, Shared Healthcare, certainly as far as any medical surgical supplies, it's mandated that it goes through Shared Healthcare. And we have done spend analysis to determine where there may be pockets in the hospital that they're still purchasing outside of Shared Healthcare, and then we target them and go after them in the most positive way to get them to see the light and start purchasing through Shared Healthcare. But it is a senior management supported mandate.
Interesting.
Yeah.
I have a couple of questions. I appreciated your talk, enjoyed it very much. And I understand the Ontario scene a lot more. But I'm wondering, across Canada, how is Ontario stacking up, say, against other areas of Canada? And indeed, how are we stacking up, say, against the United States? What are their practices? Where are they in this evolution of supply chain management?
I think that as far as the practices are concerned across Canada, that you know, if I look at it from the perspective of the healthcare supply chain network, we're doing a good job all across the country of identifying what the leading practices are and what we need to do in order to adopt them and improve our efficiencies. So I don't think that Ontario is ahead of British Columbia or Nova Scotia in terms of understanding the need to move that agenda forward, and that's why it's been really exciting to have HSCN be a national organization, because we can see, you know, what's happening across the country and see that it is fairly consistent. I mean, we're all pretty much at the same place. In terms of the U.S., while we do some comparisons with the U.S., because their healthcare system is so different, they aren't always valid. So, however, when we do our leading practice research, we'll look everywhere. So we look in the U.S., globally, in the private sector, and try to compare ourselves to what the leading practice is in supply chain anywhere.
Have you explored why it's taken so long for the healthcare sector to start this initiation? Why are we lagging so far behind, say, other industry sectors in terms of this?
A large part of it is because of the lack of opportunity to invest in technology, because the funds are directed towards direct patient care. And again, that's totally an appropriate decision, but it means that, you know, sometimes I think that it's a twofold thing. One part is the technology, so it makes it difficult to achieve some of the efficiencies that are possible because you don't have the right technology supporting you. And the second is absolutely just a lack of awareness and a focus on patient care issues. The supply chain isn't the core competency of the hospital, and so they you know, it tends to have been, in the past at least, forgotten and relegated to the basement. So that's why awareness is such a big part of what we do.
So that could explain why the education sector is even lagging further behind.
I was quite interested in your thoughts from Sunnybrook that 15% of nurses or clinician time is used running around after supplies. And I think you're saying technology is maybe one of the answers in getting the right person on the right task. But what kind of specific technology or systems are you going to be using at HBS, I guess, to address that area, to get the nurse doing the right thing and the materials management person doing the right activity?
Well, if I go back to Sunnybrook, to give a couple of specific examples there, we have done things like introduce in the cardiac catheterization lab, introduce PDAs so that the assistants who are actually placing the orders for the products, instead of writing them down on a requisition, mailing the requisition to purchasing, risking that then purchasing is going to key enter the wrong number and order the wrong product, which then has to be returned. With the PDAs, they're actually scanning the products, so there's no opportunity for making a mistake, and then the order is automatically sent through the system, and so that's the kind of technology we're putting in place to reduce error. And likewise on patient care units, just every patient care unit has a cart with products on it, and it's ensuring that we have the right technology on those carts to barcode the supplies to keep track of what's there so that they don't run out. I mean, it's some pretty simple stuff, but the technology is mostly that kind of barcode reader, handheld device that will eliminate human error to the greatest extent possible.
One of the things that we've noticed a little bit different about the U.S. approach to this model is the use of key indicators to try to set the bar as to what an efficient hospital looks like. And unfortunately, because 70% of our operating costs goes to labor, it usually means you've got more people on the job than you need. And so we have found a resistance to change within the hospital because people know if I select that system, let's face it, this is a disruptive technology, and it may cause a displacement of some labor. But the leading practices model, I guess kind of the Canadian version of it, versus the U.S. approach, it seems to me the leading practices gives you a feeling for what the inputs need to be and what it needs to look like kind of coming in. But is there any attempt to kind of look at what are the end results so that people can begin to get a feeling for what does an efficient hospital look like? And I think as a national standard, this is something we need to move towards. Certainly the federal government has been asking for it in some form of a report card. Nobody has any doubt that we'll spend the money. And we may even, in fact, engage in the leading practices, but that does not necessarily mean we'll achieve the levels of efficiency that we need to. Is there any attempt or discussion at establishing what that bar looks like so other hospitals in Ontario and in the country can get a feeling for what the end result would be if I in fact, employ those practices effectively?
There has been, and I don't know for how many years, there continues to be a benchmarking analysis that goes on an annual basis that looks at the efficiencies of hospitals. And materials management is certainly a component of that analysis. So there is an efficiency that is set, and the ministry comes back and says, okay, you must be above this particular level of efficiency. So that can be achieved by, as you so eloquently put it, let me see, what did you say? Something about redeploying individuals, or it can be achieved by implementing the leading practices. So that's one way that it should become apparent over time, because hospitals will be seen to be more efficient as they implement the leading practices. But in addition to that, I think we need to develop our own set of key indicators. So not just hospital-specific ones, but that is the type of thing that the Healthcare Supply Chain Network could be doing, that they could, through establishing these leading practices, is also putting key indicators behind them so that there can be a better survey of how hospitals are doing as they implement those specific practices. So I think that's where we're headed. We just haven't quite got there yet.
Any other questions, or Shirley?
Yeah, I have one more. You talked about OntarioBuys, and it sounded like they supported sort of like projects that you could try certain things out. Is that their approach?
I don't think it's so much to try things out. We look at the e-supply chain initiative that is underway right now, those are very specific projects that are being funded in order to improve the efficiency of the hospitals that are implementing them. The try it out part is, I think, perhaps in the sense that if it works in the hospitals where it's being implemented and it's intended to work, then it sets a platform for rolling it out at other hospitals. So it's not so much that it's experimental as it is, let's get it working right in one place, then we can roll it out somewhere else.
So OntarioBuys really determines the initiative, and then others participate in it.
Again, using the e-supply chain initiative as an example, there was a working group that was made up of individuals from the 6 entities that participated on the hospital side, individuals from OntarioBuys and from the Ministry of Finance, and they all sat at the same table and developed the project together. Okay. It was a very collaborative effort.
Mm-hmm. Which is good.
Yeah.
I guess my final point would be 2 things. One, when talking with Chris Scherback and putting their system into hospitals, he pointed out to me that even when they make it almost impossible for the user to not use certain e-commerce functionality, they still don't use it. So there's a very deep adoption problem here, very serious adoption problem. And I don't know that it's a matter of the technology, but it's probably as much a matter, as you're pointing out, of the human engagement. So that concept of education and of having people realize that this is not something that you can avoid, that the core competencies of the hospital and other areas, why not put the resources there? And if you were competent in this area, you would make use of that functionality. So it's a very interesting challenge, I think, in the large number of people involved in the supply chain in Ontario, getting them to the point of either accepting the technology and keeping their jobs, or you're going to migrate the job out of the organization. It's your only 2 choices, really, in today's world. So it's an interesting problem. And you said you were looking at educational activities. And do you have programs right now? And is there anything on the web, for example, that people can access?
We don't have anything that's web-based at the moment. The one program that we have is the program through Schulich. That's the major program. We do run individual conferences often in conjunction with the OHA, but we haven't actually morphed that yet to any kind of web-based learning initiative, although we recognize the real value of doing that. I think back to HSCN, once we've built up our repository of leading practices, that then we would link perhaps some web-based education into those leading practices, because it's always been our intent that we would make ourselves available as subject matter experts to anyone who wanted to implement one of those leading practices. So, again, that's in our future vision. We're just not quite ready yet.
This might be something where we or others could help you with regard to getting this some educational content, not necessarily in a sort of question and answer type asynchronous learning, but even good lectures that were available and that could be promoted to people in the field. And in fact, probably would be a good idea to locate some people in the field and help have them help create those materials. But if there is this big problem, this big challenge, it would seem to me that education might be something that could really bridge the gap. And without it, it's going to be either a painful process of introducing the technology or a painful process of the jobs migrating out of the sector. So it's kind of an interesting problem, and might be something that the universities, and of course Schulich is an excellent place for this, but we or others could have an effect on that kind of thing. The final point is I'd like to thank ORMED for enabling us to have you here, and I thoroughly enjoyed your talk. I learned a great deal. I started from zero practically in this area, but very enjoyable talk, and hope to have you back again sometime talking to us.
Thank you,
very
Dominic.
much.
Thank you. Thank you.
Well, I'd just like to wrap things up again, and thanks, Dominic, to giving it's sort of like the film credits at the end. We must give credit to our speaker, give credit to our great sponsor today, our seminar sponsors for the series, McKesson and the BON. And I look forward to seeing you all back on April 20th for our next speaker, Jim Anderson. So see you then. Thanks a lot.
Jim, by the way,